All right. Hello, everybody. Thanks for joining the webinar today. I'll be talking about micro-fragmented adipose tissue, or MFAT, for use in treating tendon tears. So first, a brief review of the anatomy. Tendon is a tough band of dense fibrous connective tissue that connects muscles to bones. Tendons can become injured over time due to overuse, aging, and trauma, and they often occur in an area of the tendon with inadequate blood supply. So a lot of times these tendon injuries will fail to heal and can be a source of chronic pain and disability. Some of the common tendons that we see injuries in include the rotator cuff tendon in the shoulder, the common extensor tendon at the outer aspect of the elbow, also known as tennis elbow. We see injuries to the Achilles tendon in the ankle and the patella tendon in the knee. So I'm going to briefly review the spectrum of tendon injuries that we see. First, we have your tendinopathy. This is a broad umbrella term that we use for an injury to a tendon resulting in pain, swelling, and impaired function. Now you have tendinosis, which is a subcategory of tendinopathy, which is chronic degeneration and breakdown of the tendon. So basically micro tears in the tendon, typically occurring in the area of the tendon near the attachment to the bone. So you have disruption of the collagen fibers of the tendon with disorganized repair, and that's what we call tendinosis. The other subcategory of tendinopathy is tendinitis. Now, this is a term that most patients are more familiar with. This implies inflammation in the tendon. So a tendon has inflammation, and we call that tendinitis. Now, by far, the majority of tendinopathies that we see are going to be in the category of what we call tendinosis, so degeneration and breakdown of the tendon with micro tears rather than tendinitis. If we look at patients with chronic tendinopathy and we look at these tendons under the microscope, the majority of them will not have any true inflammation. So we're not going to see any inflammatory cells. So the more appropriate term is tendinosis rather than tendinitis, although there are cases where we can see true tendinitis where there's actually inflammation around the tendon, and you can actually see these two conditions simultaneously, where you have tendinosis, a chronic degenerated tendon with a superimposed tendinitis after a period of increased activity. So you can have these two conditions simultaneously. And then these tendinopathies can progress into tearing of the tendon or tendon tears. And I'm going to briefly review the different subcategories of tendon tears. First, you have your partial tear or partial thickness tear, where a portion of the tendon is torn, but not all the way through and through the entire tendon. The picture on the left shows you an example of some rotator cuff tendon tears. So this is the supraspinatus tendon where it inserts to the humerus, the shoulder bone. And if that tendon tear occurs on the top portion of the tendon, we call that a partial thickness bursal-sided tear of the tendon, because that's on the surface of the tendon adjacent to the subacromial bursa. Now, if the tear occurs on the underside of the tendon, we call that a partial thickness undersided tear or articular-sided tear. So the tear is on the side of the tendon adjacent to the joint. And then the tear can be within the substance of the tendon itself. We call that an intrasubstance partial tendon tear. Now, if the tendon tear goes all the way through from the top to the bottom of the tendon, we call that a full thickness tear. So it's through the full thickness of the tendon. Now, you can have a full thickness partial width tear where it goes all the way through the tendon, but it's only a portion of the tendon. So in the picture on the bottom right, we see this is a top view of that same tendon. We can see a partial thickness tear of the tendon of the anterior half, so the front half of the tendon, or you can have a partial thickness or a full thickness partial width tear of the back half of the tendon. So the tear is through and through the tendon, but only a portion of the tendon is torn, and there are still some remaining fibers that are still attached to the attachment point. Now, if you have a full thickness complete tear or full width tear, that's where the tendon is through and through the entire tendon. So you have basically a complete rupture of the tendon. And that's where we can have retraction, where the two ends of the tendon can start spreading apart. So that's the different types of tendon tears, and you can see this terminology on your MRI reports. Now, how do we treat these tendon injuries? Traditional medical treatment will include rest, relative rest, modification of activity. So you try to avoid the offending activity that's causing the tendon injury. Physical therapy is one of the mainstays of treatment to improve flexibility, improve range of motion, and then strengthen around that injured tendon to reduce stress on the tendon. Non-steroidal anti-inflammatories and cortisone injections may be appropriate for certain tendon injuries when there is actual inflammation. But as I alluded to earlier, a lot of these tendon injuries don't really have any inflammation, so there's no true tendonitis. It's more of a tendon injury where there's disruption of the tendon fibers. So these anti-inflammatories and cortisone injections may not be appropriate in that setting where it's more of a tendon injury and could be actually detrimental to the healing of that tendon injury. And in recalcitrant cases, surgery may be needed, especially for the larger, full thickness, complete tears to actually reattach that tendon. Now, what about some of the treatments that we use here in our clinic to promote healing of the tendon injury? There are several things that we like to use. One of the mainstays of treating tendon injuries is platelet-rich plasma, or PRP. That's where we take the platelets out of your own blood and inject it to the site of the tendon injury to jumpstart or stimulate that tendon injury to heal. Shockwave therapy is using sound energy to the injured tendon. So the sound energy will stimulate a cell response. This stimulates the cells to release growth factors, stimulates increased blood flow and neovascularization, all things to promote healing of that tendon injury. And then we have our other cell treatments using a patient's own bone marrow aspirate concentrate, or our fat, the patient's fat, micro-fragmented adipose tissue, to help stimulate healing of these larger tendon injuries. This is the approach that we typically use in our clinic for your tendinopathies or smaller partial tears. We like to use PRP and or shockwave. These treatments are very effective for treating these type of tendon injuries where the tear is not that significant. However, when we're dealing with a more significant tendon injury with our larger partial tears or full thickness tears, we typically like to use something stronger to stimulate that healing effect. Now, why do we like fat and bone marrow? These tissues contain what we call our mesenchymal stem cells or adult stem cells. So scientifically, we believe that these have more potential for healing these more significant tendon injuries. So I'm going to briefly go over some of the stem cell basics so you can learn more about why we like fat and bone marrow for treating some of these pathology. Stem cell is a cell that has the capability of replicating or self-renewal, and it can also differentiate into more specialized cells. Embryonic stem cells are the cells in an embryo which have the capability to differentiate into any different cell in the body. So these are considered our pluripotent stem cells. So that cell can become a liver cell, a brain cell, nerve cell, a bone cell. And then we have your adult stem cells. So these are the stem cells that live in our adult tissues in the vascularity. These cells can differentiate into cell types specific into the tissue in which they live. So they're a little more further down the lineage compared to pluripotent stem cells. These are considered multipotent, so they can still differentiate, but not into any type of cell, a little more specific into the tissue in which they live. Now, these adult stem cells are found on the vascularity, quiescent, they're inactive, but they become activated in a time of injury when needed for tissue repair. So if you suffer an injury, these stem cells will become activated, go to the site of the injury to try to stimulate that healing response. So your mesenchymal stem cell, the adult stem cell, was discovered in 1991 by Dr. Arnold Kaplan. Now, this particular type of stem cell is of particular interest to us in orthopedics because these cells can differentiate into the tissues that we are interested in healing. So bone, cartilage, muscle, tendon, and connective tissue. So where are these mesenchymal stem cells located? We can find these in our own bone marrow. We can find them in our adipose tissue or fat, and they're also present in birth tissues, umbilical cord, Wharton's jelly, and amniotic tissue and fluid. So in orthopedics, we like using bone marrow and we like using fat to help regenerate or heal different orthopedic injuries. Bone marrow aspirate concentrate is where we aspirate your bone marrow, concentrate it to concentrate those mesenchymal stem cells plus platelets and all the other regenerative cells in that bone marrow, and then inject that to the site of the injury or tendon that we're treating. Micro-fragmented fat, adipose tissue, where we do a liposuction type procedure, harvest the fat, and then concentrate, rinse, wash, and inject that into the tendon tear that we're treating. And these are considered to be compliant with FDA as long as we follow certain rules, doing it in the same day, not manipulating the cells, and so forth. So these are considered FDA compliant therapies in orthopedics. Now, if you compare bone marrow to adipose tissue, which tissue source has a greater number of these mesenchymal stem cells? Well, by far, we know that adipose tissue has much more abundance of these mesenchymal stem cells compared to bone marrow. If you aspirate bone marrow, of all the cells that you're getting, actually only less than 1% of those cells is a mesenchymal stem cell. So very low numbers in bone marrow, whereas in adipose tissue, we're getting much more abundance of these mesenchymal stem cells. What about these birth tissues, amniotic fluid, umbilical cord, Wharton's jelly? These were at one point legal, okay with the FDA, but since around 2021, all these tissues are no longer permitted by the FDA. So there are a few clinics still out there offering these treatments, but this is considered illegal and not permitted by the FDA. So we don't use these tissues in our clinic.
Just to clarify, they were never legal. The FDA was liberal in their regulation of the space. So there was this discretionary period, which, as you stated, ended. And the reason why these are not permitted by the FDA is because there's very limited data on their safety. There's actually been some issues with some of these products that are not produced in FDA inspected labs. So we don't use them, and doctors aren't permitted to use them.
Exactly. So as far as treating our larger tendon tears, when you're comparing microfragment adipose tissue to bone marrow aspirate concentrate, we definitely favor using your fat to treat these tendon tears for a few different reasons. One, again, as I alluded to earlier, greater number of these mesenchymal stem cells are going to be present in your fat compared to bone marrow. Two, the number of the mesenchymal stem cells in fat doesn't decline with age, whereas in bone marrow, we know that as you age, the number of mesenchymal stem cells will decrease as you age. Three, the harvest procedure, much less painful with fat compared to bone marrow. I've done both, and by far, definitely fat is much well tolerated. A lot of times, patients don't need any type of sedation. We just use numbing medicine for the skin. Whereas in bone marrow, definitely tolerable, but I would say moderate amount of pain when we're aspirating the bone marrow from the bone marrow cavity because we can't really numb that. Going in the bone's not the problem, it's the aspirating that bone marrow, that negative pressure in the bone marrow cavity is very painful, which we can't control. And then probably I think the biggest reason why I think fat is a huge game changer for treating these larger tendon tears is that fat, when we inject that fat into a large defect of the tendon, so into a larger tendon tear, that fat will actually fill the gap and provide a scaffold for the cells to actually potentially heal that tendon tear. Whereas with bone marrow aspirate concentrate or even PRP, if you inject that, that is really a liquid. So that when you inject into a larger tear is just going to spill out of the tear, not going to really stay there to heal that defect. Whereas the fat really sticks in there and I think has definitely a higher propensity to heal these larger tears. So the MFAT procedure is a pretty simple in-office same-day procedure, basically where we sterilize and then numb the skin. Then we first inject the tumescent fluid. The tumescent fluid is a type of mixture of anesthetic with epinephrine, and it's to prep the area for the harvest. And we typically will harvest the fat from the upper gluteal region or flank. So we inject the tumescent fluid first, and then we let it sit for 20 minutes and then do the aspiration via a liposuction type procedure. And then we take that lipoaspirate, rinse, wash, we can concentrate it and fragment it and then prepare it for the injection. And then the micro-fragmented adipose tissue is injected into the tear using ultrasound guidance directly into the tear. The bottom video, this is the fat. So we're kind of micronizing and fragmenting it, getting it nice and fine, ready for the injection into the tendon tear. So let's review some of the studies on MFAT for using it for specifically for tendon tears. This is a study using MFAT published in October 2023 by John Farrell et al. He presented it's a case report. He presented a case of a 70-year-old right-handed female with right shoulder pain and weakness for 8 months, had failed traditional conservative care. The MRI showed a full thickness tear of the anterior half of the supraspinatus tendon, so a full thickness partial width tear, so not the entire tendon, but the front half of the tendon was torn, and there was some low-grade partial tearing of the posterior part of that tendon. Patient underwent the MFAT procedure, also had a PRP injection 9 weeks after. Patient had significant improvement in pain and function. And what was pretty cool was that a follow-up MRI 9 months after the procedure was read by a radiologist who didn't know what procedure the patient had done. And he read it as status post rotator cuff repair with scarring and attenuation of the supraspinatus at the footprint related to post-surgical changes, but no recurrent full thickness tear was identified. So this radiologist thought that the patient had undergone a rotator cuff surgery repair, when in actuality, the patient had the MFAT procedure. And the next slide, we can see a pretty nice healing, a pretty remarkable healing of that supraspinatus tendon tear. On the left, you can see the tear. That tendon should insert all the way onto the bone, but we see that big white gap where that tendon is torn away from the bone. And then the MRI 9 months later shows nice healing of that tendon back to the attachment following the MFAT procedure. So pretty remarkable before and after picture. Next study published, another case report published just last month, October 2024. This was using MFAT for a full thickness common extensor tendon tear. This author reported a patient, a 56-year-old male with a full thickness tear or rupture of the common extensor tendon with retraction. So meaning it had completely ruptured off the attachment point and retracted. And apparently it's happened following a cortisone injection. We know that cortisone carries that potential risk of causing tearing and potential rupture of the of tendons. And so this patient underwent the MFAT procedure and ultrasound performed 15 weeks post-treatment. So almost 4 months post-treatment showed complete bridging and remodeling of the tear with resolution of the retraction. Now, unfortunately, I don't have the before and after images. I don't have complete access to the entire article, so I wasn't able to look at the before and after ultrasound images, but that sounds pretty amazing because this is something that typically you would treat surgically to reattach it.
Yeah.
But this patient did well with the MFAT.
And I'm gonna add the standard of care currently in most orthopedic practices is to do a cortisone shot, and if that doesn't work, do surgery. And I think the evidence is pretty strong now, indicating that most of these patients will not benefit from a corticosteroid injection, or at least not get long-term relief. We've heard of patients, and back in the day when Ed and I were injecting cortisone more frequently, we would treat these patients and we would see benefit, but typically the data is pretty consistent that you don't get the long-term outcome, and there's this added risk of tendon rupture as occurred in this case. So I think we can pretty safely say that in most cases of tendinopathy, tendon tear, steroids are really contraindicated and not helpful. And so that's why it's so important to highlight this, that's really what most clinics will offer. So if it were my elbow, actually I did have a tendon tear in my elbow, and I would never have steroid injected into it. The other point I'll make is if somebody injects anything into that tendon, make sure it's under ultrasound guidance. It's important that the doctors see exactly the defects, the sites in the tendon, so they can administer whatever it is they're injecting into that defect.
Great. Okay, the next study I'll present is this is a case study presented or published in November of 2022 using MFAT for an Achilles tendon tear. So this is they presented a patient with 1 year history of right Achilles tendon pain and weakness due to a partial intrasubstance tear of the Achilles tendon, treated with MFAT. Patient showed progressive healing, resolution of pain, and return to all activities, which was maintained at 6 months follow-up. Again, I don't have full access to this article, so I don't have the before and after images. And then even the surgeons are starting to catch on with using MFAT, thinking that, because of that regenerative capacity of your fat tissue, they're starting to do it with surgery to see if they can enhance the surgical repair and improve their outcomes, decrease the re-rupture rate, improve healing, and accelerate patients' recovery following surgery. So this was a randomized controlled trial published in April 2022 in the American Journal of Sports Medicine, where they treated 44 patients with rotator cuff repair surgery. Half of those patients had MFAT injected at the time of surgery, and the other half had surgery without the MFAT injected. They had found that the MFAT group outcome score was statistically better than the control group at 6 months. So indicating faster healing in these patients. Now, they didn't see any change in the other endpoints. So at 1 year, 2 years, outcomes were the same, but they concluded that injection of autologous MFAT is safe and effective at improving short-term clinical and functional results after rotator cuff repair. So the ultimate outcome may not be better, but definitely looked like there was faster healing in the patients treated with the MFAT.
That's relevant because there are clearly cases where surgery is indicated, and patients can have good outcomes with surgery. However, anyone who's been through the process knows that it's a long road, it's a long recovery from a rotator cuff repair. And so anything we can do to accelerate the healing and get that patient back to function, minimize the effects of deconditioning, muscle atrophy, et cetera, is needed in this space.
Agree. This is another study using MFAT during surgery. So this was published in October of 2022, looked at 8 patients who underwent surgical repair of an Achilles tendon tear in conjunction with having MFAT injected at the time of surgery. And they compared these 8 patients to a similar group treated with surgery alone without MFAT. Both groups had similar outcomes, but they did see ultrasound showed quicker remodeling in the MFAT group, suggesting enhanced healing following the MFAT. Again, similar to the rotator cuff study, it seemed like there was faster healing when treated with the MFAT. I'm going to go over some case studies. So this is a patient of Dr. Rogers, treated a few years ago. Professional golfer, full thickness rotator cuff tear, shoulder pain for a year, was offered surgery, but he decided to pursue trying the MFAT procedure. He was able to return to golf in 2 months, and follow-up ultrasound showed significant 90% healing of that large tendon tear. You can see the before and after ultrasound pictures on the right side. So the red arrow pointing to the large defect in that supraspinatus tendon, so that big black area. Then 1 year after the procedure, we see nice healing of that tendon tear. Pretty remarkable.
Yeah, I was shocked when I saw this. This patient actually came back a year later. You know, he's a professional athlete, so he's traveling all over the world. He actually won a tournament 2 months after I treated him, which surprised me because I told him not to play any golf for 2 months, but he's an athlete, right? So, and but he came back with the other shoulder having a problem. So I said, hey, while you're here, let's take a look at the one I treated a year ago. And I was shocked to see how much tendon healing there was, because while I had experience treating smaller tendon tears, at that point, I hadn't treated too many patients with these large retracted tendon tears. And so it was really a complete shock to me to see how much healing there was.
Yeah, I love seeing the before and after ultrasound and MRI pictures, because that really, sticks out in my mind as well. We're more concerned about, is a patient doing well with pain, function, return to activities, but to actually see that tendon healing is always like a nice surprise.
The key findings for those who don't look at ultrasound, that arrow is pointing at the black area, which is the defect where the tendon has pulled away from the bone, which is the kind of dark, or the bright white signal under the arrow. The tendon is kind of the gray area to the right of the arrow, and you can see it's swollen, it's thickened, and also it doesn't have that color. Whereas the one a year later, the image below, you can see the tendon is not as swollen, it's not as thick, and also you can see it's brighter. So it's not a light gray. I mean, it's not a dark gray, it's a bright white, which tells us there's a lot of thick, mature collagen fibers that have grown into that tendon, giving it that strength.
Yeah. All right, next image is a before and after of a patient with tennis elbow, so a large tear of that common eccentric tendon at the attachment right at the elbow. On the left, you see the big black hole in the tendon at the attachment point, so that's the tear. And then 5 months after the MFAT procedure, nice healing of that tendon tear. Again, pretty remarkable seeing that.
Yeah, again, a case where I was completely shocked to see this. There's a patient who's in her mid to late 60s. She's an avid pickleball player, an avid golfer, just always doing something physically active. And you just see that massive tear in the elbow. And then again, surprised to see healing so quickly after treatment. I'm going to add to the technique is evolving, I would say. I started injecting fat into tendons maybe 8 years ago. I would say we're still learning. Later, you'll hear that we're tracking data so we can see how different doctors are getting different results, so we can move the field a little bit quicker along. But one thing's for sure is distributing the cells throughout the tendon, not just the injured defect area, but also throughout the healthy parts of the tendon seems to make a difference. So this is again where ultrasound guided injections are critical. You can't get the cells where you want them without that ultrasound guidance.
Agree. Yeah, and the other thing is we don't always see these nice before and after pictures. Some patients come back and sometimes they're still doing great, but you look at the tendon with ultrasound, there is still, some abnormality going on, not completely healed. But yeah, a lot of times these patients can still do very well, because sometimes the pain is not coming from where the defect is. It's those fibers that are remaining that are still painful and hanging on. And so I think that's why still a lot of patients do well, even if we don't see complete healing of the tendon tear or the defect.
And in a case like this patient also has ligament injuries that need to be addressed. And in some cases, if they go on too long, they can start developing osteoarthritis in the joint. So again, it goes to technique. And just like a good surgery, these injection procedures require good technique and need to address all the affected areas to get the best results.
Yep. Next case is Achilles tendon tear. You can see on the top picture the tendon or the attachment, the tear. And this patient underwent MFAT with PRP and showed nice healing of that tendon defect following treatment with good resolution of pain. This is a nice one. Another patient of Dr. Rogers, male professional soccer player, knee pain for 2 years, considering retiring, underwent the MFAT procedure for you can see the patella tendon intrasubstance tear, that defect in the tendon on the top picture. That black area is the intrasubstance tear of the patella tendon, and then 3 months after the MFAT procedure, nice healing of that defect and return to soccer in 3 months. Again, pretty amazing.
I think the other 2 points to make, this guy worked really hard on his rehab afterwards. And so to get a good outcome, it's not just about doing a good injection. It's about having that comprehensive rehab program. And for him to be able to play at the professional level again at 3 months is pretty remarkable, considering it had been 2 years. He'd been struggling. He'd actually had PRP at another clinic 2 times, I believe, just indicating that there are cases where PRP is just not sufficient to get the job done. And you have to go to something that has a different biology, a different biologic effect.
And this is so we're trying to track our data, as Dr. Rogers had mentioned, to see how our patients are doing, see if the treatments we're doing are working. So this is, I'll let Dr. Rogers, you want to go over this slide?
Yeah, anybody who's been at our clinic probably has filled out surveys. So we ask patients to fill out a baseline survey. It's usually 10 to 15 questions. Depending on what body part we're treating, the questions will vary. So for example, if you have a tendon tear in your knee, we'll ask you, how are you having trouble walking? Are you having trouble going up and down stairs? And you'll get a score. And then that will be repeated every 3 months so that we can see trends in function and trends in pain using different treatment protocols. We have over 330 doctors now using this database. I originally built it with 2 other doctors about 6 years ago, I think, or 7 years ago. Can't remember. But it's grown to where it's now become the industry standard. So regenerative medicine doctors around the country use this to track their patients. So I just pulled up on this slide. I queried the database. I said, find any patients who had tendon tears who were treated with MFAT. And so you see it pulled up 249 cases that we tracked for 12 months. And their average pain level, I don't know the exact number, but it's higher than 5. So maybe that's 7 or so at baseline. And then you can just see this steady improvement in the level of pain. These are tough patients. These are patients in their 60s. So this is when we commonly see tendon injuries. I tell everybody, if you're 65 and you go to your high school reunion, 2/3 of your classmates are going to have a tendon tear in their shoulder. It's just extremely common. And you can see on the left here, the little pie graph showing that most of these patients were in their 50s or 60s or 70s. So these are not 20-year-old athletes. These are just regular working folks and who are getting up there in age and their tendons are tearing. And we can show that their pain is reduced. And then on the next slide, you'll see we ask them to report their functionality. So it's just a subjective 0 to 100%. So if you have no problems whatsoever, you're 100% functional. And you can see function levels going up pretty quickly. It looks like most of the data was at baseline and at 6 months. That's why it's a straight line. As we get more and more data, we'll see even more granular data. And by the way, these were tendons, not just shoulder and knee, but also hip and elbow, it looks like, in this population. But the vast majority of them were patients with tendon tears in their rotator cuff in their shoulder.
All right.
I started collecting these pictures years ago. So the first patient I treated maybe 8 years ago with a full thickness tear of her supraspinatus. And I asked her how she was doing, and she did this. She raised her arm up overhead and said, "Look, I can raise my arm and it doesn't hurt." So I thought, well, that was kind of cute. So I took her picture, and then more and more people started doing this for me. So so now I have like 40 of these pictures now with people, but these are just some of the folks showing us how they've improved using cell therapy for their rotator cuff tears.
All righty. So that's it for the lecture. Yeah, the fat has definitely been a huge addition to, doing PRP, and I was doing a lot of bone marrow, but the fat for these large tendon tears really, I think, has been a huge addition to the practice and our armamentarium.
Agreed. Frankly, it's a game changer for my practice. I've been able to treat things that I previously could not treat. So somebody has already figured out that there's a Q&A section down there at the bottom. You see, I don't know, maybe halfway across the bottom there, it says Q&A. If you click on that, I think you can type your questions and we can see them. Let me see if I can see them. Yes. So the first question is about cost. So the thing that always comes up is, why doesn't insurance pay for this? These are not reimbursed by your standard medical insurance. And as you saw by some of the data we presented, this is very early, right? So these are case studies. These are small prospective clinical case series. We don't have placebo-controlled randomized clinical trials yet. So frankly, I'm surprised that there aren't more published papers because it is so effective in our clinic, as you can see in our data. However, we're just not there yet. And so the insurance companies have been slow to adopt it because it's still considered new. Even though I've been doing this almost a decade, it's still, I was one of the early adopters. It's still considered to be new. The cost varies depending on what we're treating. So it can be, anywhere from 5,000 to 10,000, depending on how many parts are being treated and how involved is the treatment. So we customize it to the individual. Plus, we may combine it with physical therapy. We may combine it with Shockwave, which is the machine that's sitting behind me. We may combine it with other types of treatments. So the customized program will, the price will vary from one person to the next. Typically, the more chronic the injury, the more severe the injury, the more expensive it is to treat it. So don't wait. I've had so many folks, and I'm sure you have too, Ed, over the years, they'll say, oh, I was just expecting it to get better. It's been, 3 months, 6 months, a year, 5 years, I'm like, how long are you going to wait for it to get better? If it's not getting better, come in and at least let's get a diagnosis. Let's at least see what your options are, and I'm just as guilty as everybody else. I think you were too, probably when you had your rotator cuff tendon treated.
Yeah, there is data for these rotator cuff tendons that if you have a full thickness tear of the rotator cuff, the chances that it will progress over time is, fairly significant. So you can definitely make an argument to try to get these tendons treated earlier rather than waiting. Yeah, because if you can save that tendon and prevent it from progressing or preventing a partial thickness, progressing to a full thickness or a full thickness, partial width into a complete, I think that would be beneficial.
At a minimum, get an ultrasound exam, get an MRI, know what you're dealing with, knowing what your prognosis is, so you know whether it's appropriate to ignore it or not. And then if it's, and then most of the time physical therapy will be helpful. So it doesn't have to be a big financial investment. But just don't, we're seeing these folks come in with these massive tears and we can help them, but I would much rather treat them when they're small tears.
Agree.
What is used for pain, doctor, during the procedure?
Occasionally we'll give a patient Xanax just to relax you, but the procedure is surprisingly very well tolerated. Not much pain during the procedure. So we numb the skin. We numb the skin before, the initial at the harvest site. And that, after that, there's not too much pain when we're injecting the tumescent fluid. The tumescent fluid has numbing medicine in it. So we're kind of numbing the area as it's getting these cells ready, the fat ready for harvest. And once we start the harvest, there's usually very little pain. So we don't use any sedation except for the Xanax, oral Xanax sometimes beforehand if the patient wants, and then just the numbing medicine.
I can attest to what you just said is true. So, I treated several hundred patients collecting fat from them, and no one ever really complained, and everyone did really well with the procedure. So that I was confident that it was a comfortable and tolerable procedure. But the true test was when I had my fat collected, and I was very pleasantly surprised. It was even less uncomfortable than I imagined it would be. To the point where the next day I hiked like 12 miles and I had no issue whatsoever. So it's a standard mini lipoaspiration procedure, as you said. I'm going to add also one of my other jobs is I do clinical research on adipose-derived MSCs, which are, as Ed said, mesenchymal stem cells. The MSC is not yet, when it's processed a certain way, is no longer compliant with FDA regulations and guidance. However, you are able to, at the same time that we're treating a tendon tear using your fat, we can take a little extra fat and send it to a facility, a lab. It's what's called GMP facilities, an FDA inspected lab that can grow the MSCs in culture and store them for future use. So very similar to what people do when they bank their children's umbilical cord blood. You know, the umbilical cord blood also has MSCs. So those of us that are older that didn't do that, you know, we don't have our umbilical cord anymore, but we still have these MSCs in our fat. And so we can have a bank of MSCs available for future use once it becomes an FDA-approved therapy. So I did that. That's how I learned what it felt like to have lipoaspiration. So both my wife and I and many of my friends have banked our MSCs, and it's really cost effective to do that. And you can ask us in person if you want to learn more about that program. Can you use this technique for a labral tear?
Theoretically, you could. However, I think for most labral tears, we're still using PRP.
Yeah, I agree. I mean, just like everything, there's labral tears and then there's labral tears, right? So some of them need surgery, but the smaller ones do very well with PRP. Whether or not it heals the labral tear completely is probably debatable, but it certainly does improve pain and improve function.
For a patient with a very old injury with maybe retraction and atrophy present, will the treatment still be recommended and effective? If it's very old and there is retraction with atrophy of the muscle, then it's unlikely that we're going to save that tendon. We like when the tendon ends of the tendon in a complete tear are still not too far retracted, because once the tear retracts too far, then the MFAT isn't going to be good enough to heal that large of a defect, especially if there's atrophy.
The question is very appropriate. Will the treatment still be recommended and will it be effective? So as we indicated, the efficacy is something that's still being evaluated. So we need prospective randomized clinical trials comparing it to placebo. One study that we did not present was one of the first MFAT studies ever published by Dr. Striano and Dr. Malanga. I believe it was 2017 or 2018 that the study was published, and they had 20 patients who had very severe, not only full thickness severe tendon tears, but also had osteoarthritis. And they were able to show that, I believe the numbers were something like 80 to 85% of those patients showed improvement in pain and function at 1 year follow-up. And so when we decide whether or not to recommend a treatment, we're weighing the known efficacy rates of one treatment versus the known safety and efficacy of another. So for example, in the case of surgery, we know what the safety and efficacy are. So all treatments are based on a risk-benefit analysis, which includes cost, right? So it's really individualized per patient.
Patient with AC joint spurs and full thickness rotator cuff tear, what is the outcome? A good question. I think it really depends on, we really have to evaluate clinically what's going on in the patient. Number one, is there a significant weakness? Is the tendon full thickness complete, or just part of the tendon with some fibers remaining? That's definitely healable. And then second is, are the AC joint spurs causing significant narrowing of the space where the rotator cuff travels? If there's a huge spur in the area where the rotator cuff travels, we can potentially heal the tendon, but if that spur is still there, it could potentially re-tear it. So it really depends on, so we look at MRI and evaluate with ultrasound to see if healing that tendon with the MFAT is worthwhile. I had a similar situation in my left shoulder rotator cuff tear where my AC joint was arthritic. I had a huge inferior spur going right into the rotator cuff. And I knew if I just treated the rotator cuff tear, it was going to keep coming back. As a surfer, I'm always paddling overhead, and I could see where that spur was just tearing the rotator cuff. So I actually had the surgeon I had the bone spur shaved off to open up the space. And once that happened, I had PRP after the surgery to heal the tear, because I didn't want the downtime of having a rotator cuff repair, and the tendon completely healed. There's space now for the rotator cuff to travel, and I'm pain-free.
But you represent the patient who had the absolute right indication for that surgery. I personally think, and I think there's good data on this now, that the subacromial decompression surgery that you're talking about, where you go under and trim off bone spurs, is probably overutilized or over-recommended, because there's two parts to the equation. The issue is, if you have the tendon sitting below the AC joint, but it's sitting above the humeral head, so sitting above the ball of the shoulder. And like you said, there can be scenarios where the bones are so close that the tendon is just repetitively traumatized. But the part of the equation that gets ignored a lot of times is the fact that the humeral head can move away and create space. And so when you have a dysfunctional rotator cuff, when the tendons are torn, the muscles are atrophied or deconditioned, there's a tendency for that ball to ride up. And I've had cases where before treatment, on physical exam and on ultrasound exam, I can see this riding up of the humeral head. Once we get the rotator cuff tendons healed, once we get this muscles strengthened, the head no longer rises. It stays seated in the socket. And so if the bone spur is small enough, then there's no need to go in there and do that surgery. So you can remedy that situation non-surgically as well.
Yeah. Is the procedure useful for ligamentous injuries?
Again, a great question. So ligament, tendon connects muscle to bone, a ligament connects bone to bone. In the simplest definition, they're made from similar cell types. They're made from similar tissue, predominantly type 1 collagen, manufactured by tenocytes. And so we could extrapolate our tendon data to ligament, but there have been limited number of studies published. Actually, none come to mind. Can you think of any studies where a ligament's been?
I didn't come across any ligament studies.
I will tell you, I do include it in my treatment if it's indicated, but I don't have solid data that we can quote yet. So I think it's worth considering. I think biologically and from a mechanism of action standpoint, it makes sense, but we don't have the clinical data yet.
Yeah.
Any other questions, folks? You've been asking good questions. I think one thing that doesn't get asked enough, I think, is safety. So whenever you, as a patient, whenever you see a physician, expect good service, meaning they should give you a diagnosis that you understand, and it should be a complete diagnosis. So for example, we're focusing on the shoulder because it's such a commonly injured part of the body, but what is the status of my tendon? What is the status of my muscles? What's the status of the joint, the shoulder joint? What are my options? What are the pros and cons of each option? But also, what's the safety of these procedures? So, we're very fortunate. Ed and I both can claim that we've had no complications when treating patients with this technology. Patients are sore for several days afterwards. It is an injection, and we're injecting into tissues that will become inflamed. Part of that we want. Some of that inflammation is good because it stimulates a healing process that is necessary. But we mitigate that pain and inflammation with medication and ice and rest, as you would in any other injury. But long-term, no adverse events so far, and I'm not aware of any reported by any of our colleagues around the country. This is still very new, so it's not like there are millions of these being done every year. I mean, I would be shocked to hear if there were more than 1,000 of these done every year. But it is something that is showing really good promise. I think the benefits are way better than expected, given our limited understanding at this point. And so I think asking questions about safety as a patient is important.
Yep. I had one other comment. So the one downside to the MFAT procedure is if a patient comes in and they don't have any fat, then That's one scenario where, you know, I'm like, I want to treat with MFAT, but they don't have any fat. That's the one downside with the procedure. You need to have a patient have a good amount of fat to
That's a good point.
harvest.
Yeah, that's a good point. Fortunately, many of those patients are young and lean and healthy, and so they have a decent amount of cells still in their bone marrow, and so that's an option. But there may be some other options that we can explore on a case-by-case basis with a patient. But you're right. Yeah, I never thought that I would want to see fat on my patient. Yeah. We don't need a lot, just to give you some context. So for example, for a rotator cuff tendon, 1 to 2 tablespoons of fat is more than enough to treat a tendon tear. If a lot of our patients have multiple injuries, so that I've treated patients 2 shoulders, 2 hips, 2 knees, need a little more fat. But typically it's 1, 2, or 3 at the most areas that we're treating. It's very well tolerated. Actually, I think it's more comfortable than PRP, to be honest. I don't know what your experience is, Ed, but I find patients are a little less sore when we inject tendons with fat than when we inject with PRP.
Yeah, I agree.
And I just think it's because the MSC content is so hot. I mean, I can't say I know, but given what we do know about adipose tissue, being very rich in MSCs, I think, given their known ability to modulate the immune system, is a part of it.
Yep.
They're also analgesic. So MSC, I mean, we get actually next week, I think I am doing a whole lecture on MSC. So anybody who wants to attend our webinar next week, we're talking about the mesenchymal stem cell, which we're just calling the MSC today, and review some of that literature as it relates to osteoarthritis. But one of the superpowers of the MSC is it releases molecules that act as an opioid. So they'll bind to opioid receptors, and they're actually a natural painkiller. And they can do this for months. They can do this for 6 months at a time. So I think maybe some of the benefit we're seeing early on is also related to that mechanism.
Yeah.
Any other questions? A common question I get is, am I going to look skinnier after this? And I say, the good news is you're not going to look worse, but the bad news is you're not going to look better. So we're not plastic surgeons. We're not, this is not liposuction. This is what we call fat grafts, MFAT graft. So we're taking fat from one place and then we're putting it somewhere else. And this is why the FDA permits it, because we're using FDA-approved devices to process the fat. So basically, essentially, we rinse it, we wash it, we push it through some filters to break it down into little pieces, and that satisfies the FDA's requirement for minimal manipulation. And then we're using it in a way that's very similar to how maybe a skin graft, surgeon taking skin from one place and putting it somewhere else in a burn patient, or taking a vein from the leg and rebuilding the coronary arteries or bypassing the coronary arteries. So I think the FDA looks at that as the risk of this procedure is less than those procedures. So that's why it's permitted. No other questions, folks? Let me see if anybody raised their hand. Well, I guess class will let out early today, Ed. It's a nice day out here in San Diego, so go outside and play, get your exercise. Thank you so much for your interest. And Ed, thanks for an excellent presentation of the data. If you'd like to learn more, you can find us online at sdomg.com. Actually, if you go to our YouTube channel, we will post this lecture along with I think we've done 70 or 80 other videos that are on our YouTube channel. So just go to YouTube and look up San Diego Orthobiologics. I tell my patients it's a really great way to put you at sleep at night, watching those videos or learning a little bit about something that you want to learn about. But thank you for your interest today. And Ed, anything else you want to add?
Oh, yeah. Thanks everyone for coming.
Thank you guys. Have a great day.
Bye-bye.